This is the case description of a 26 years old female who was morbidly obese but had no comorbid illnesses. She was hospitalized under pleural service with pyrexia and gradually progressive exertional dyspnea. Thoracic ultrasound revealed multiseptated pleural effusion on the right side of the pleural cavity after we obtained a chest radiograph. This is the chest radiograph of the patient. You can see a large non-homogeneous opacity on the right side, which is occupying the right middle and the lower zones, causing obliteration of right heart border as well as the right hemidiaphragm and both CP angles. Rigid medical thoracoscopy was planned. Adhesiolysis was carried out with the rigid biopsy forceps. All the pleural fluid was taken out. There were small pockets of fluid, and here you can see that the lung is adherent with the chest wall through multiple thick adhesions, the fibrinous adhesions between the visceral pleura and the parietal pleura. The blunt dissection was carried out. At 6 o'clock position, you can see the lung, and these are the adhesions, the septations between the visceral and the parietal pleura, and they were lysed successfully. Post-procedural chest radiograph showed some remaining fluid loculations on the right side. The chest tube was placed at the end of the procedure. Now you can see this is the chest radiograph showing the chest tube, but still some remaining fluid collection on the right side. So intrapleural streptokinase was given. One injection was divided in 6 equal doses and was injected intrapleurally twice daily for 3 days, and this led to much clinico-radiological improvement of the patient. There was great improvement of the radiological opacity, and no more fluid was being drained after we removed 1200 ml of pleural fluid, so drain was removed successfully. The lab analysis of the pleural fluid showed a high protein and LDH levels. The fluid was exudative with lymphocyte predominant. AD levels were high. The Zn stain for AFB was negative. Mycobacterium tuberculosis DNA was positive in the pleural fluid, and histopathology was consistent with the presence of caseating granulomatous inflammation. The final diagnosis was a multiloculated complex tuberculous pleural effusion. A combination of anti-TB drugs, EHRZ, ethambutol, rifampicin, INH, and pyrazinamide were started, and the patient was asked to come back after 4 weeks with a fresh chest radiograph, and you can see dramatic improvement on the chest radiograph. There is just slight blunting of the right CP angle, and the right hemidiaphragm appears slightly horizontal, but otherwise the chest radiograph is much clear. The patient was clinically better, and she was advised to complete the course of anti-TB drugs.